We've been cutting it down to the wire, Robin and I, over the last 24 hours, and her presentation with her voice has just come through, so this is perfect timing. But before we hand over to Robin, our keynote speaker, I want to ask you a question. What do these four characters have in common? We have Snow White, Luke Skywalker, Voldemort, Oliver Twist. Can I have a response? Right, they're all four of them. Their mothers died delivering them. Very common theme in literature and in movies, but also a really key feature in our history. You read Exodus and they name the midwives. They were so important. Very early book of the Bible, 1500 BC. Lucretia Borgia of Machiavellian fame died after giving birth to her 10th child. Elizabeth York, the wife of Henry VII, died after a postpartum infection or sepsis, as did two of Henry VIII's wives, both Jane Seymour and Catherine Parr, although admittedly Catherine Parr died with having had a child with her fourth husband after Henry VIII himself had passed away. We would never have had the Victorian era had not Princess Charlotte, the only legitimate heir of George IV, died in 1817. She had a protracted labour. It was so traumatic that her celebrity, Mr. Croft, Akusha, committed suicide 3 months after her delivery. But perhaps the most famous monument to maternal mortality is the Taj Mahal. Many of you would know that this monument was erected to Mumtaz Mahal, the wife of Shah Jahan, in 1631. She's an amazing woman. She was 38 when she was delivering her 14th child. She was on a campaign with her husband, so she was far away from her home, from whatever health facilities existed in 1631, and had a labour that then lasted 30 hours, followed by a postpartum hemorrhage. The reaction in India was, apart from building this magnificent building, was 2 years of mourning for the whole country. But what is fascinating for me, I think, is that right across the other side of the world in Sweden, in the same time, in the 17th century, Queen Ulrika Eleonora was also responding to high levels of maternal deaths that affected her close friends. She didn't build the Taj Mahal, but she mandated that 1 or 2 women in every village across Sweden should be trained in midwifery. And it sort of led to the very first midwifery school opening in Stockholm in 1708. So with this history in mind, it's great to consider where we are today, particularly in light of the SDGs. Their targets are ambitious, as were the MDGs. And here to discuss the global agenda, we have Robin Gorna, who is currently sitting in a hotel in Johannesburg. Sadly, the universe didn't align to have her standing here this morning, but we are very pleased to have her presenting from Johannesburg. Now, I will give you the choice, Robin. We have your presentation with the recorded voice has just come through, or would you like to present it live?
Oh dear, that's it. I'll let you decide. I feel more confident if it went from the recorded version, so you go with that.
Okay, I think that's a good idea because we all know how trustworthy Skype can be when you really need it. So if you'll just give me a few minutes to set this up.
Right?
Now it's coming now. We've got it.
Just working on the technology, Robin.
We had to transfer it from one computer to another.
Yeah. Robin, it might be good to turn your volume down on Skype.
Yeah.
Your end.
Robin, your Skype volume's quite loud. You might turn it down a little.
Thank you for your patience while we get this set up. While we get that loaded onto my computer, I just want to introduce Robin to you. Robin took over the Executive Director role in the Partnership of Maternal, Newborn and Child Health in Geneva in January of this year. There are many people in this room who know Robin very well from her work in HIV. She's got very good form in Australia, was the President of the Australian Federation of AIDS Organisations for many years before moving on to be President of the International AIDS Society. It is a real honour that she's given up the time and most of her night to be with us today from Johannesburg, and I think we now have this working. So we'll try the audio, and we've got Robin here, should it be... But do you know how to make the audio work? The audio is coming through. Should it be automatic? Robin, we might go to plan B and have you present if that's all right.
That is perfectly fine. I've tried to turn my Skype volume down. Has that worked or not?
We can turn the volume down here. We've got Phil's managing our sound for us. So I will get the presentation up and we will let you go ahead. Over to you.
Well, thank you, Alison. Thank you, Barbara, and thank you to everyone in Australia. I cannot tell you how profoundly disappointed I am not to be with you. And thank you so much, Alison, for your flexibility and resilience in coping with this very unexpected situation. I am deeply honoured to have been invited to give this presentation, and will do my very best to do it from a hotel room in Johannesburg instead of the beautiful city of Melbourne. And let me also acknowledge all of the leaders in the room. I wish I knew who was there, but I'm sure I will get to find out who's there as we carry on through the day. And I also want to acknowledge the traditional owners of the land, and say what a pleasure it is to be back in somewhere in Australia. So thank you for the opportunity to be with you today. My presentation is about this tipping point that we are now at, moving from the MDGs into 2030 era of the Sustainable Development Goal. And what I hope to touch on during the presentation is the concern that many have expressed that as we've moved from the MDGs to the SDGs, that we've lost space for our gender of sexual, reproductive, maternal, newborn, child and adolescent health. A very clunky acronym, and I'm sure we could throw in a few more letters to that acronym. And I hope that what we will see is that the updated global strategy on women, children and adolescents health that was launched is indeed a front runner to that. And I want to touch on a few issues associated with that. So if we go to the next slide and think about the MDGs that we're all familiar with very well. So the next slide, please, Alison. So you're all familiar with the 8 Millennium Development Goals that are coming to an end this year. And as we know, amongst those 8, there are 3 on health. So on to the next slide then, just to reaffirm the points that Barbara has already touched upon in her opening comments, we have seen substantial progress on MDGs 4 and 5, which are the focus of the Partnership for Maternal, Newborn and Child Health up to date. And since 1990, the global under 5 mortality rate has dropped by 49%, from around 90 deaths per 1,000 live births in 1990 down to 46 in 2013. And we've seen a reduction of the rate by 52% or more in all regions except Sub-Saharan Africa and Oceania. And if we look at the next slide, then we can see that despite the substantial gains, this progress is insufficient to reach MDG 4, particularly in Oceania, Sub-Saharan Africa, Caucasus, Central Asia and Southern Asia. And we still face the scandal of an estimated 63 million children dying every year under the age of 5, with 17,000 preventable deaths of children under 5 every day. 2.6 million babies are stillborn. And so if we just go back a slide there, if we look at MDG 5A, or forward one, sorry, back one more, we can see with the maternal deaths, as again as Barbara mentioned, we've seen a 45% decrease down to 289,000 in 2013, and the global MMR has declined by 45% over that same period of time to 210, but we're still off track from the MDGs. And then when we move forward 2 more slides and look at target 5B of the MDGs, we see that in terms of the universal access to reproductive health, there has been an important increase in contraceptive use, but there are substantial gaps. And at this point in time, there's still 225 million people globally with an unmet need for family planning. So the summary on MDGs 4 and 5 is good progress, substantial progress, but they're not likely to be achieved. And for example, in the East African region, only Rwanda is on track to achieve all 3 MDGs. MDG 6 does show a happy picture. This is a slide from UNAIDS' most recent report looking forward, and you can see on the left-hand side of the slide clear progress with not only achievement of most aspects of the MDG in terms of HIV by 2015, but also a very strong and encouraging trajectory for the future to the agenda of zero transmissions and 0 deaths. But if we touch on the right-hand side of the slide, not only do we see the reflection that celebrity champions have played a key role in this, but also these indicators on children and adolescents are quite substantially off track, so masking an overall positive picture. So moving on to the next slide then, what does this mean for the future? So on the next slide, what we see is the transition from the millennium to sustainability. Our 8 MDGs, 3 of which had a direct focus on health, translating the 2030 agenda to 17 SDGs, only 1 of which is focused directly on health. So on the next slide, I just want to share with you the 17 Sustainable Development Goals that have just been agreed, as Alison said, at the SDG Summit in New York. And it was a great privilege to be there and to hear the sort of excitement and vibrant energy around this new agenda and the integration of issues that have been had before. But for us, does this mean we are being left behind in this overall agenda? Well, here you see on the next slide, SDG 3. So if we go forward, we see that SDG 3 is to ensure healthy lives and promote well-being for all at all ages. And as you can see in the box below, there are 9 targets within this, 2 of which are very directly focused on the legacy issues from MDGs 4 and 5, a reduction of the global maternal mortality ratio to less than 70, 100,000 live births by 2030, to end preventable deaths of newborns and children under 5, with the aim of reducing neonatal mortality to at least as low as 12 per 1,000 live births, and under 5 to at least as low as 25 per 1,000 live births. And then if we look at 3.7, we have the ambition by 2030 will ensure universal access to sexual and reproductive healthcare services, including for family planning, information and education, and integration of reproductive health into national strategies and programs. But there is substantial concern that this one SDG pulls together everything that existed under 3 MDGs before, and that there's a dilution effect. I want to move forward and suggest that there is actually some optimism in the SDGs. So if we move forward, I'd like to just reflect on the fact that there are SDGs, such as SDG 2 on nutrition, the SDG to end hunger, achieve food security, improve nutrition, promote sustainable agriculture, explicitly reflect some of the health issues affecting the populations that we're most focused on. So we know very well the intergenerational impact on nutrition and the health impacts of it, and these are reflected here in the targets that speak to the needs of infants, adolescent girls, pregnant and lactating women. Moving on then next to SDG 5, on the next slide we see the importance of the integration of an SDG which is focused on gender equality and empowerment of women and girls. And I know that there are great concerns that MDG 5 has progressed more slowly than MDG 4 because of an inadequate focus on gender equality. And here we see within this SDG reference to at least 2 targets which speak to issues which underlie health inequities amongst women. And most importantly, I want to flag that SDG 5, target 5.6 on the universal access to sexual and reproductive health and reproductive rights is a more ambitious target than 3.7 in that it embraces human rights for the full ICPD and Beijing agendas. Moving then on to SDG 6. SDG 6 is our new Sustainable Development Goal focused on water and sanitation. And again, we see within that at least 3 targets which reflect the needs of women and girls or speak to the health agenda. And I'm not going to go through all 17, but if we just look at the next slide, there are other health-related SDGs, such as the SDG on equitable access to quality education, that specifically speaks to the vulnerability of Indigenous people and children, for example. We've also got the issue of inequalities within and among countries, and I'll come back to that. And of course, the importance of global partnerships, something very important to us, the PMNCH, but I think to the whole community. So on to the next slide, just to summarise that we do stand at that historic moment that you mentioned, Alison. The world we want in 2030 is expressed in the SDGs. And our generation now has the knowledge, the opportunity and the resources, knowing that the survival, health and well-being of women, children and adolescents is absolutely fundamental to achieving all the SDGs. So let's move forward to the next slide. And here I just want to transition into discussing the global strategy, which was presented by the UN Secretary General at the SDG Summit. And in presenting it, he framed this as the front runner of the SDGs. So on this slide here, you see the front of the global strategy for women's, children's and adolescents' health, which is our global roadmap for the next 15 years through to 2030, building on the success of the first global strategy launched by the Secretary General in 2010. And that first global strategy is credited with having galvanised political leadership, attracted billions of dollars in new financial commitments, and created the Every Woman, Every Child movement, which brought together a powerful multi-stakeholder movement for health. I think the 2010 global strategy was so important in lifting the profile of how tremendously off track we were with maternal and child mortality. And the hope is that our new global strategy will update that ambition. If we look at this next slide here, I don't expect you to be able to read the fine print, but what this slide tells us is and reflects an image which is within the global strategy itself, is how this global strategy was developed. And it's a radical story of having developed a global strategy in the same way that the SDGs were developed, which is by relying on the inputs from thousands of individuals and organisations from around the world. This is a people-owned strategy in the way that the SDGs have come through a broad process of inclusion. Now clearly that has its challenges, as any of us who've ever tried to write anything by committee would know. But at the same time, there's a democratisation of these global goals and this global agenda through that process, compared to both the MDGs and the global strategy, which were written by very small numbers of people closed in locked rooms. This went through an extensive process of discussion in all regions and through multiple face-to-face meetings as well as virtual consultations, which I am the partnership happy to lead. In addition, technical papers fed into the discussions behind the global strategy. So what did all this energy and discussion result in? Well, if we go to the next slide, you'll see the vision. The vision that has defined the global strategy is of a world in 2030 in which every woman, every child, every adolescent, in every setting, realises their rights to physical and mental health and well-being, has social and economic opportunities, and is fully able to participate in shaping sustainable and prosperous societies. And I think that you can hear in that vision statement that it's a step significantly beyond the more survival-focused agenda of the MDGs. There are key guiding principles behind this. As I say, this is people-centred, it's community-owned, it's a human rights-based approach, it's about equity and gender responsiveness, and it's country-led. If we look at the next slide, these are the three objectives of the global strategy. So on the next slide you see that the objectives and indeed the subheading of the global strategy is survive, thrive and transform. There is no doubt that we must end preventable deaths. We need to deliver on the unfinished agenda of the MDGs. But there's no point in surviving if we don't thrive, and so one of the radical conclusions in the global strategy is the stress and emphasis on ensuring health and well-being. And then thirdly, very much in line with this comprehensive agenda of the 17 SDGs, is transformation, expanding enabling environments, and really thinking about how health contributes to societies and how societies contribute to health. On this next slide, you'll see the targets that sit within the global strategy. These are fully aligned with the SDGs. I'm not going to read through them, but they all sit in the existing 17 SDGs. Some have suggested that instead of talking about the SDGs as leave no one behind, we could talk about them being leave no target behind. This is just a subset of the targets in there, and there was quite some debate and disagreement as these targets were finessed as to which category they would sit within and why some were selected rather than others. But what you see here is the survive targets basically deliver on the three MDGs that are unfinished and bring in some of the issues that we've just been hearing about in terms of NCDs and mental health and well-being. Under Thrive, we then begin to pick up this broader agenda of the SDGs around malnutrition, early childhood development, pollution-related death and illness, very importantly, universal health coverage. And then in this Transform section, we begin to think about some of the other sectors, and I want to touch on those again later on. Onto the next slide then, how are we to deliver this global strategy and achieve these ambitious targets and these goals? Well, 9 action areas have been identified, and these have been derived from scientific evidence and practical experience gained from implementing the first global strategy in the MDGs, and all of the inputs that were received from the massive consultations and technical drafting. There's been substantial new research into effective interventions and approaches, as well as new thinking about the integrated nature of health and sustainable development. So what you see in these 9 areas is that we need to interlink our actions, but to ensure that country leadership is prime, that we secure adequate and sustainable financing for health, the resilience of health systems, as we've just heard about in such clear and detail, but also in the same way as delivering the best services, also maximising the potential of individuals and the engagement of communities. The action at a multi-sectoral level is fundamental, and humanitarian and fragile settings are key to this new global strategy. recognising we need to improve health in every setting. Research and innovation is clearly fundamental, and accountability has been long-standing as an issue and an approach in global health for maternal and child issues, and that retains its central space. So moving to the next slide, one of the things that is extremely clear is that if we implement the global strategy with the increase in sustained financing that's needed over the next 15 years, there will be tremendous returns on that investment. So it's not just a rights issue, it's the right thing to do for countries. We will end preventable deaths, we will end stillbirths that are preventable, and there should be at least a tenfold return on investments through the social and economic benefits we receive. The estimates are that $100 billion in demographic dividends would be received from early childhood development and adolescent health and well-being, bringing us to a grand convergence in health. We're not simply moving forward, however, so if we go on to the next page, next slide, I do want to emphasise that the continuum of care remains central to the thinking of the global strategy and to the work of our partnership. This approach of the continuum of care was seen as something quite radical 10 years ago, and it's now quite fundamental to the way we think and our recognition that we have to work across all the different stages of this continuum to have the range of impacts we seek, that maternal health and neonatal health and child health intricately linked. Moving on to the next slide, what you see is another aspect from within the global strategy, emphasising how high impact interventions that are based on evidence are essential across the life course. And within the global strategy there is a comprehensive list of evidence-based high impact interventions, and this will be updated through virtually through the life of the global strategy. I think one of the things that was very important in developing this is that what you see in the middle row is the intervention packages. So for example, in women's health, screening and management of cervical and breast cancer, pregnancy and childbirth, the issues of antenatal care, management of complications, in child health and development, breastfeeding, immunisation, in adolescent health and development, prevention of injuries and violence, management of communicable diseases. So all of our intervention packages, but also critically along the bottom, the enabling environment. The health system enables the infrastructure issues, the policies for universal health coverage, and the multi-sector enablers, the policies and interventions that enable this to happen, education, water and sanitation, and so forth. Moving to the next slide, what then is so new about the global strategy and this SDG era that we need to reflect on? And there are four key aspects: equity, adolescence, transformation, and universality. So fine to move forward to equity, and one of the fundamentals here is around focusing on reaching the most vulnerable and leaving no one behind. And again, I think we began to hear about that earlier. So let's move to the next slide. This is a very striking graph, I feel, which displays the proportion of under 5 deaths in the poorest and richest quintiles by country. And it's ranked according to the percentage of all under 5 deaths that occur in the poorest quintile. So what we see here is that very clear depiction of the fact that health outcomes among women, children and adolescents are worse when people are marginalised or excluded from society, affected by discrimination, or live in underserved communities. What we see here in the very top row is that about half of Brazil's under 5 deaths are occurring amongst the poorest quintile, and that blue bar on the top is in the poorest, and you see in the top right-hand corner a relatively small number of under 5 deaths in the richest quintile. But this issue of equity isn't just related to income quintiles. We also know, for example, that up to 3 times more pregnancies occur amongst teenage girls in rural and indigenous populations globally than in urban populations. And when we then look at issues of education, we, for example, see a 39% higher prevalence of stunting in the children of mothers with no formal education compared to those children whose mothers completed secondary or higher education. So moving on to the next slide, let's look just at a couple of country examples. India is well regarded for the substantial progress that has been made towards MDGs 4 and 5A. In 1990, India was known for carrying 40% higher burden of child mortality compared to the global average, but the under 5 mortality rates in India declined at a higher rate than the global decline, so that the rate of decline doubled from 1990 to 2008, when the decline was at 3.3% to 6.6% over the next 5 years. In maternal mortality, it's even more striking. The decline has been at an accelerated pace, and it's now reached a figure lower than the global average, projected to reach the MDG goal by the end of this year. And there are many factors behind India's progress, including a significant increase in investment and a massive effort with the National Rural Health Mission, focusing at the national, state and district level with new interventions at that level. However, on the far right-hand side, what we do see, again, is this issue about socio-economic inequities in coverage, most striking at the level of antenatal care, 4+ visits, and skilled attendance at delivery, where there is such stark difference between the poorest and the richest 20%. Looking then to this region, and I'm quite nervous saying anything about the region because I know I'm amongst great experts here, but you'll probably be well aware that in the Solomon Islands there's been very good progress made towards MDG 5A, with a little less progress on MDG 4. But coverage along the continuum of care is quite mixed. Percentage of live births attended by stillbirth attendants remain relatively high. The proportion of women accessing antenatal care is only 5%. And there's a substantial impact on the rather patchy policy and regulatory environment. And then finally, then the next slide in this set is looking then in Ghana, where again you can see on these pictures from looking across selected indicators, again there's substantial difference across income quintiles. Again, most marked around skilled birth attendant, but also very clear in total fertility rate, where in 2008 the total fertility rate is still running between 6 and 7, just over 6 for the poorest quintile, but it's close approaching 2 for the richest quintile. And then if we move on to the next slide, just wanted to make a point that as we think about equity, it's not just about poverty levels, it's also about geographic reach. We held our board meeting in Zambia just under 2 weeks ago to agree the partnership strategy to respond to the global strategy, and I was very struck by this from the Ministry of Health. Very impressive that they are beginning to disaggregate data by sex and age as well as by geography, and seeing that they are starting to address how they can target services to reach the population more fully. I think what this slide shows is the really substantial gaps across the country, and one of the reasons why many East and Southern African countries are struggling so much with high rates of cervical cancer. Here you see that the red districts are the ones with no screening at all, the dark green with optimal screening of both LEAP and VIA, and the light green only VIA. So as we think about our move forward in the global strategy and the SDGs, this issue of equity, leaving no one behind, is key. So the second area I wanted to touch on, which spans the SDGs and the global strategy, is adolescence. It's one of the most visible changes to the updated global strategy, is that it is now a global strategy for women, children and adolescents. On the next slide you see an admirable summary of the many health challenges that face adolescents. And one of the criticisms of the previous global strategy is that adolescents were the missing middle between children's health and maternal health. Here you see on the right-hand side the pregnancy-related issues facing adolescents, but of course health for adolescents is far greater than the sexual and reproductive health aspects. But as we move on to the next slide, I think one of the really important aspects of the SDGs and adolescence is not just to think of adolescence as health problems, but the real importance of adolescence as a potential for change. Here in sub-Saharan Africa, where I sadly find myself today, over 50% of the population are under the age of 20. And this image comes from here in South Africa, where there's an extraordinary campaign called Fees Must Fall, which you may be aware of, a real tipping point in the political life of South Africa, led by some extraordinary, strong young women. And we're beginning to see how adolescents are driving policy change, they're driving society, and so they are, in a very real way, the SDG generation, holding enormous potential to transform popular opinion on key issues. If we move to the next slide, then I just want to remind us of this point about the demographic dividend, this estimate of $100 billion US. And it's suggested that if countries in demographic transition from low to middle to high income status, as we used to think of them, if they make the right human capital investments and adopt policies that expand opportunities for young people, then it's thought that their combined demographic dividends could be even larger, and that in sub-Saharan Africa, it could run at least 500 US billion a year, which is about a third of the region's current GDP. So why then is investing in health so important in adolescence? Well, there are the discrete issues that face young people, the health challenges, but it's not only the fact of those challenges and how they impact adolescents at that stage of their life. We've talked already today about non-communicable diseases, and 70% of preventable adult deaths from NCDs are linked to risk factors that start in adolescence. So there's a complex relationship between when diseases will have the greatest impact throughout the life course. Moving on then to the next slide, just to reflect on one of the key issues facing adolescents globally, which is HIV. And it's estimated that over 2 million adolescents were living with HIV in 2013, the majority in sub-Saharan Africa, and the majority of those not having their HIV status. And with an extremely inequitable impact between young women and young men, where the age differentials are substantial, in part because of age discordant sexual behaviour. I think the most striking statistic I find about adolescents and HIV is the difference in the fall in AIDS-related deaths. We've seen that MDG6 is well on track in most countries, with a fall in deaths of 40% between 2005 and 2013, mainly because of good access to treatment. There have not been that fall in deaths amongst adolescents, so we continue to see a substantial issue there. And my final slide on adolescence is the next one, about adolescence, teenage marriage and pregnancy. 1 in 3 girls in developing countries will be married by the age of 18, and 1 in 9 will be married by the age of 15. This isn't only a human rights abuse and the challenge to any educational opportunities and social opportunities for these young girls, but early and forced child marriage has massive health impacts. 11% of our births worldwide are occurring amongst teenage girls, and amongst those teenage girls, 90% of them are already married when they become pregnant. And you will all know very well about the significant complications that occur in teenage girls carrying pregnancies, such as obstetric fistula, and in addition to the risk of communicable diseases. One of the reasons, and thanks for moving to the next slide of transformation, so one of the reasons to reflect on this is this point about how the health-related issues impact on health. So let's move to the next slide. This point about transformation is fundamental to the SDGs and to this comprehensive approach of the 17 issues. Last year, the partnership MNCH, working with WHO and the World Bank, conducted and published what's known as a success factor study. And what the team did was that they looked at countries to try to understand why some of them had had a much greater impact on child and maternal mortality than others. And the headline finding was that since 1990, around 50% of the gains in mortality reduction are occurring because of investments in the health sector. And the other 50% of the impact was occurring through investments in the other sectors. That's sectors like gender empowerment, countries like Rwanda, where there's an incredibly high rate of women in parliament doing so much better. It's focusing on nutrition, on education, on water and sanitation, on infrastructure. So this focus, this finding from the success factors has been very important to us all in thinking about what should be included in the global strategy and how to respond to the SDGs. So let's look at the next slide and just to emphasise one of the points that I made earlier. So we've talked a lot about these quintiles issues and the deaths relate very much to poverty. But let's look at the bottom part of the slide here on mothers' education. This is data from DHS in 49 low middle-income countries over a 7-year period. And what you can see here is how under 5 deaths are so much higher amongst those with the lowest wealth quintiles, but also the enormous impact of a mother's education on a child's mind. So we see here that those mothers who have had no education, there's over 100,000 live births that is the rate of death for the under 5s, compared to the women who've completed secondary school. Their children have got almost double risk of survival. And then let's look to the next slide, which is one of the case studies from success factors from Laos. And you see here the significant progress made towards MDG4 and that they have met MDG5. So, as well as the slides which clearly show those reductions in mortality rates, the slides don't show is that over the same time period, Laos managed to move from a 54% primary education rate for girls to near universal access in 2012, when 95% of the girls were able to access primary education. Similarly, over that time frame, they increased access to clean water for all population groups from 40% to 70%, and poverty has reduced substantially over the 20-year period. So I think Laos is a very interesting example where there's been significant scaling up of health interventions, birth spacing, early and exclusive breastfeeding, essential immunisations, malaria prevention, vitamin A supplementation, but also a huge emphasis on the policies and programmes in health-related areas, and that has a huge synergistic approach. On to the next slide. I don't think we should assume that this multi-sector approach is simply something we've learned about maternal and child health here. It's something that's been the cornerstone of effective responses to AIDS, and as Alison mentioned, that's very much been my history before moving from MDG 6 to 4 and 5. And the Global Fund, with its CCMs, engages a variety of stakeholders and makes sure that all of the different sectors get involved in planning and delivering programs, deciding how money is spent, building upon the successful National AIDS Council models that have been in place in countries for 20 years or so. And if you look at the slide which you've already got up there, fantastic. I couldn't be back in Australia, at least virtually, without commenting on Australia's HIV response, and hopefully I'll find out who else is in the room soon, but Helen Evans, I know, played a critical role in this, as I'm sure did many others present today. And this very successful response that Australia had from the earliest days of the epidemic were due to this partnership response and this integration of all sectors in responding and making sure that those communities and individuals most affected by HIV were central to the response, alongside clinicians, researchers, provincial and national governments. And so I think that this is a model for us all that relates very strongly to the SDGs. So moving to the next slide, just got two final aspects of the SDGs and the global strategy to comment on. And the first is the point of universality, and I think that that's essential and very, very important to this new agenda. So if we look at the next slide, we'll see there the graph that you'll all be very familiar with about how significantly varied globally the issues are and the rates of maternal and child mortality. One of the things that's hugely exciting about the SDG agenda is that, unlike the MDG agenda, this isn't just speaking about addressing health in low-income and middle-income countries, if we were to use that terminology. And I think this reflects back to the points on inequity, and one of the things that I learned very much from my time working in Australia was about the substantial inequities within the country, and particularly the impact on Indigenous Australians and Torres Strait Islanders, and how we could see levels of ill health in some of those populations highly comparable to countries with low-income status. So that's part of the agenda of the MDGs. And if we look here at this slide on the women's health challenges that you were just showing, what we see there is that some of these challenges are very strongly represented in some of the poorer countries of the globe, but many of them are also massive challenges in richer countries too, including cervical cancers, physical and sexual violence. So this is an agenda where we need to respond with the pockets of inequity where they exist. And looking then at the next slide on child health challenges, again we know that these challenges occur obviously many times related to poverty, but not only related to poverty. I was recently at the WHO Euro Committee, and they are the region of the world most off track for the breastfeeding targets that we have. so that we see that these challenges are varied across the globe. Then my final slide in this area then is just to pick up this, I think, quite interesting picture from Washington, DC, a place that we may think of as being one of the richest cities in the world, and yet when you look at the disaggregated data, you discover that black males in Washington, DC have a rate of HIV which is on a par with rates of HIV in urban Nairobi, Kenya. So the agenda of the SDGs is to focus wherever the need is so that we genuinely leave no one behind. So on to the next slide. How will we do that? Well, we hope that we will do that through partnerships. I mentioned that we recently had our board meeting in Zambia, and this is a picture from the hospital we had the pleasure of visiting there, where we saw some phenomenal work going on, partnership between local government, development partners, and some extraordinary healthcare workers delivering to the needs of a huge population there. And as we met there, what we were there discussing was this particular slide, the Every Woman, Every Child architecture. This also comes from the global strategy. And what it shows is a picture with a smile in the middle, I think, which emphasises that as we move forward to deliver this global strategy in the SDGs, countries must be at the centre of what we aim to achieve. That country leadership is key. The smile in that green circle reads multi-stakeholder engagement platforms. So we need to find a way to ensure that we live what we've identified as being most successful. And these are not always as in place as they should be in all countries, or as strongly involving all stakeholders. And around the edge of that circle, we see a circle that grades from green to blue. And on the left-hand side at the top, we see the role of our H4+ UN agencies and their partners supporting and planning implementation efforts in countries. Along the bottom is the need for money, and the global financing facility that was recently launched in its investors group has a key role there. And along the bluer side of the circle is our role as the partnership to engage and align global stakeholders and to drive forward accountability. The UN Secretary General continues to take leadership of this through the Every Woman, Every Child movement, and will be supported by a high-level advisory group. So as we move to the next slide, this is the vision that the partnership has agreed in Zambia as our vision for moving forward in the next 5 years. And it is the vision of the global strategy that I just want to remind you of, and how important we feel it is that we unite together and bring together all of the different partners. Currently within our partnership, we have over 700 partners involving the UN, and we have 8 different constituencies with donors, civil society, private sector, very importantly, healthcare providers, and of course, researchers, as well as country governments and young people and adolescents, all united to deliver this vision. On the next slide, the results that we've set ourselves are to make sure that these multi-stakeholder processes really do align partners, and that we prioritise this engagement with countries. That we drive forward accountability that is unified, independent, and mutual accountability. So we hold each other to account for the results, for the use of the resources, and for holding human rights at the heart of our response. That we focus our action for results, working in the right places with the right people, and we deepen our partnership to bring others together. On the next slide, you see how this responsibility that we're adopting around accountability is being envisaged, and we are going to be responsible for taking on the Independent Accountability Panel, which is the successor to the IERG that will be established at the start of next year. And then finally, just to emphasise in terms of the next steps with implementing the global strategy, an operational framework is being developed that will be launched next month, and that will then be discussed at the World Health Assembly next year. And as a partnership, we are strongly committed to working with all partners to accelerate action on the unfinished business of the MDGs. And then, very importantly, to accelerate action where needed, learning and evidence gathering on frontier and other critical challenges, so that we can build our knowledge and experience with intersectoral collaboration. And I do very much hope that this will be a partnership that brings together many of you in the room today. And I look forward to the debate and discussion as we move through the day together. Thank you so much.
whether you can see everybody in the room there, but we've got some roving mics, I think, and if you are somebody who would like to ask a question of Robin, or indeed of Barbara, please put up your hand and we will translate that to you, Robin, if you can't hear.
I'm hearing fine.
Thank you very much. So have we got any questions? We might take a couple and then we'll get a response from Robin that might make it easier. So put up your hand if you want to ask some questions.
Okay. Thank you. My name is Lucy. I work at CBO Australia. My question is for Robin. In terms of the equity analysis that has been done, how much or whether that's considered the interaction of disability in terms of equity of access to both maternal and child health services?
We might take 3 or 4 questions and then get a response together. So there are some other hands up. Don't be shy, put them up. Okay, we've got one. Thanks, Tony.
Hi Robin, I'm Samuel. I just want to ask a question. It is good you are working in Africa, or you are in Africa at the moment, but you are responsible for global health. My question is, there's a lot of money poured in for many years to solve the problem of child and maternal health, but still there are some countries which are lagging behind. For example, countries in most part of Africa and Southeast Asia. Is it because the failure from a health expert, or it is failure from the government, whom you are working in collaboration? Thank you.
Just thought we'd start off with the easy ones. Any others? Okay, we've got a question. Tony?
One of the problems, breastfeeding...
Do you want to introduce yourself?
Oh, sorry. Maureen Minchin. I've worked in infertility issues for nearly 40 years. And one of the problems of promoting breastfeeding, which is implicated in virtually all of the MDGs and the SDGs as well, is that we have conflicts between a culture that has normalised artificial feeding to the point where we actively need to enable breastfeeding, not just for the first few days in hospital, but thereafter. And yet in Western communities, there are very few resources put in place to support that. And in a culture where artificial feeding is the norm and is actively promoted by major industries, how on earth are we going to reclaim exclusive breastfeeding for 6 months? That is a major issue when you're dealing with something that affects gene expression, affects healthy microbiomes, affects brain development, differences in white matter tissue, ranges of things that are happening, but all that education and so on. So the lead, breastfeeding almost disappeared and then came back in small sections, but it once was seen as being essential in some of those early programs and WHO. How seriously are we taking the need to control artificial feeding, advertising, marketing, promotion? Not as government's capacity to lactate, so much as women's belief that they can within Western communities, and we provide the health.
Thank you. So, Robin, I don't know whether you caught that last question, but we've got a question about what contribution does disability play to the inequities, and do we fully understand and document that? Sam was asking about why are some countries lagging behind, particularly is it a sort of health, we're not improving our health investment very well, or is it a government problem in terms of the poor progress in some settings? Although I reckon Rwanda's had the fastest reduction in child health in the world, and Ethiopia met all 8 MDGs, so there's some vast improvement there. And then the third question was around breastfeeding, that we have culturally normalised artificial feeding, that the industrialised or the richer countries are the worst examples of this, and so there's not good models of good practice, and it's sort of added with the vested interests of those that manufacture artificial feeds. And it was a big priority of UNICEF and WHO in the past. How are we going to sort of recoup the benefits that breastfeeding can have? I'm not sure whether the sound is suddenly gone very difficult. There are a lot of background noise at your end. Is there? Ah, that's better. No?
Because I muted it.
Oh, right. Okay. Okay. Oh, that's much better. Great. Did you catch those questions? We'll hand over to you.
I did hear the first question. You might want to mute your microphone, it might make it easier. I don't know whether that's any better. Wave at me if it's terrible, and I'll shut up and type the answer. But I did hear the 3 questions, and they're excellent questions. In terms of the first question on disabilities, as we were working on the consultations for the global strategy, we did indeed have a number of discussions, both with organisations representing people with disabilities and also in some of our discussions in the East African region. In particular, this issue was raised. I'd have to say, in my observation, we don't have sufficient evidence and research, and it's something where we really do need to pay much greater attention. So it certainly has been raised a great deal in the discussions, and we did put in as much effort as we could to make sure that those concerns were reflected in the global strategy, but it's definitely an area where I think we need to be paying much, much more attention and not making assumptions and sustaining the invisibility around disability issues, both in terms of access and the delivery of appropriate services and ensuring that we're responsive to the needs correctly. So I think it's an important issue moving ahead, and I think it's somewhere where we don't have sufficient energy behind it. So I'm very keen to see us to do more on that through the partnership and through the organisations that are already working with us in our civil society group to do so. Moving on to the second point about Africa and funding, I was delighted to hear, Alison, you picked up the point about Rwanda and Ethiopia, and I think they are very interesting examples of why some countries in Africa are doing well and others are not doing so well with the resources available. And I think in the case of both Rwanda and Ethiopia, we see incredibly strong governments with very forthright leadership at both the Prime Ministerial and Health Ministry level, where they're able to really garner their resources and quite frankly be very strong with development partners. I think, Samuel, your point is very right. There have been huge amounts of money given to countries on health, which don't seem to be resulting in the level of impact that we would be expecting. I think that's why accountability is so important moving forward. It's also why I'm quite excited about the GFF, the Global Financing Facility that was launched earlier this year in support of the Every Woman, Every Child movement and deliver the global strategy. What's fundamental to the GFF is that it will bring together country governments with development partners and with other players to try to make sure that the resources are pooled as effectively as possible, or if not pooled, at least that they are aligned behind countries' priorities, so that countries can take a greater steer in terms of making sure that the resources are invested where there will be the highest level of impact. Now that's not a straightforward action, and it's been something that development partners have wanted to do for a long time, but I think that we know from the countries that are successful that if we don't get strong government leadership alongside resources, then we're not going to see the results that we need to have. But we also need to have communities and researchers involved and healthcare professionals to make sure that the programs are right. And then finally, in terms of promoting breastfeeding, I think the questioner has put it all extremely clearly in the question, and I'm not too sure what to add except to say that I do think these are critical concerns right now. I was very shocked when I looked at some of the data in the European region. I think in the UK, our rates of breastfeeding just at 1 month are still just 4%. So it is clearly hugely problematic. In terms of the organisation, the partnership, we obviously exclude organisations that promote breastfeeding, as does WHO, from engagement. So there's obviously many actors involved in promoting the code and so forth around artificial feeding. But yes, I do agree that we need to do an awful lot more to promote exclusive breastfeeding. I think there's also a critical issue in countries that are in transition, where becoming wealthier at a population level and also within the communities is often associated with moving to artificial feeding, and so taking more strident action in this area is clearly essential. I'll put myself back on mute now and hand over to you, Alison.
Okay, thank you. I think we might have to hold off on further questions now. Robin is very kindly staying with us during the day, even from Johannesburg, so there will be other opportunities to interact with her. But I think in the interest of all the other presenters who are here, we want to make sure that they also get a go. So can we also give Robin a huge round of applause? Amazing to be able to deliver that. You'll never have to leave Geneva again, I suspect, and we'll be ticking off on our environmental sustainability with this precedent. What I'd like to do now is to invite our next panel